Okay, so for agenda item number 3, we will discuss and take possible action on presentations about the uses, risks, and side effects on teens and young adults of psychotropic medications, including medically assisted treatment to treat substance use disorders, especially in detention settings. Probation will share their role in ensuring youth have access to psychiatric medical care through their partners and the impacts they see, positive or negative, of the use of psychotropic medications. Dr. Gongora, please proceed with introducing this item. Thank you.
How's this? Okay. So I just want to thank everybody. I want to thank the commissioners for putting this on the agenda. No?
I think it's not connected to the speakers in the room.
Okay, is that better? No. Yes. I hear my voice echoing. I know I have a loud voice.
I think you have to bring it closer, maybe.
Just closer? Oh, okay. All right. So I just want to say thank you to our commissioners for putting this agenda item onto the conversation today. And thanks to our DMH and probation panelists for coming in. The discussion about psychiatric services and psychiatric medications made available to young people in detention is an important topic. I think that every time that we enter facilities to do inspections and to do other sorts of visits, we're always hearing from officers and line staff and from DMH partners about the seriousness of psychiatric symptoms that our young people are experiencing during their detentions. Mental health is often at the absolute forefront of conversations and concerns about young people in detention. And psychiatric services are a major, important, critical part of treating young people and helping them to manage the symptoms they experience, right? And so when young people are in detention, we often hear that young people are experiencing symptoms of depression. They're dealing with addictions that they have grappled with on the outside. They're dealing with attention deficit, which can affect their school performance and other ability to manage impulse throughout the day and different behaviors. And they're also dealing with symptoms resulting from trauma. So, psychiatric services can be a really critical piece of helping young people to manage those symptoms and helping them to get through their day a little bit easier, and helping them in conjunction with different therapies to move forward and to be able to experience a higher level of well being. So, what I'm hoping that can happen in today's conversation is that there can be a little bit of data that's shared, obviously, about who receives meds, how many young people are receiving meds, what that looks like, but to really have a discussion through the lens of centering young people. What are the effects to young people? What are the trends that psychiatrists are seeing that young people are facing when they're coming into detention? And how do they stabilize? And, for those who are taking medication, like what does the future look like for those young people, as we're, as I think Oversight, always thinking about reentry back into the community. I also think I would be remiss not to mention that the Centers for Disease Control a couple of years ago put out a study that said that children in the United States, aged 5 to 17, I believe was the age range, had a use of medication for mental health at about a rate of 9.3%. And we see rates that are much higher in detention facilities. And so to be able to have this conversation about what young people really need, the challenges they're facing, and how ultimately any services provided are affecting them, including if detention is having any effect on the need for psychiatric medications. So anyway, I just want to thank everyone for being here and would like to hand it over to Dr. Demerla to lead our conversation.
Thank you, Dr. Gangara. First of all, I want to thank good morning to everyone, and I want to thank the commission for having me. And is it better? Oh, great. Thank you so much for having me, having us. I'm joined by Dr. Michael Fitzpatrick, who's my colleague. He's a child analyst psychiatrist who just took over my previous position as supervising psychiatrist and medical director for juvenile justice. And I'm Hanu Demerla, chief psychiatrist for the forensic psychiatry division of Department of Mental Health. And having said that, I really appreciate your introduction, Dr. Gangara, that we have a very significant topic today, and it's especially significant because there is a lot of suffering that youth go through, and then especially in the detention facilities, we do see a lot of diagnoses, and we do see mental health diagnoses, and coupled with substance use disorders. And I think psychotropic medications, and when I say psychotropic medications, that includes medication-assisted treatment as well, which is mainly for substance use disorders, because we in DMH, we do believe in treating both of them. And I think one without the other, you may be, you may not be getting the desired outcomes. So having said that, I must say that psychotropic medications are an important component. I would not say it's the be-all, end-all of everything, but it's definitely a very important, a very significant component of treating a youth and what they're going through and dealing with them, addressing their needs at that point of their life. Having said that, I think there are two tracks to medication, to treatment. One is definitely the medication wherever it's necessary. And the other part is definitely all the supports that we get from our other partners, from probation, because they have care, custody, and control of the youth in the facilities, but more importantly, also from our DMH colleagues, our clinicians who provide the necessary support, individual therapy, and also this group therapy in our facilities, and including involving their families, and also aftercare. And we do have juvenile justice transitional outpatient treatment services, JJ TOTS, which I've mentioned to this commission previously, that where DMH follows them in the community, into the community. So with respect to medications, I think in some instances, medications are adjunct, as in they are, a part of the entire treatment plan. Like, for example, you mentioned depression earlier, Dr. Kangara. So in that instance, I think medications are important, especially when the diagnoses of depression and anxiety, they are more severe, more significant, then medication needs to be prescribed. But in some instances, medication can also be the mainstay. But even like, for example, in attention deficit, which you mentioned, there's a lot of evidence that to state that in certain disorders like attention deficit hyperactivity disorder, or for example, bipolar mood disorder, or for example, in primary psychotic disorders, which, like for example, schizophrenia, medications can be the mainstay, which is primary treatment. But in certain other conditions, like even with depression and anxiety, and even with trauma, which we should talk about, because we do see a lot of youth with a lot of trauma-related diagnoses in these population. They've seen a lot at a very young age, and there are significant symptoms that they suffer from on a day-to-day basis. So in those instances, medication can be very helpful in just to use the expression leveling the play field, in the sense that if they're having a lot of symptoms, agitation, and if they're feeling very angry, irritable, frustrated, medication prescribed in a thoughtful way, which we will talk about, can actually alleviate some of that suffering. So they're able to, the anxiety and the frustration and the immediate irritability that gets alleviated to a significant extent, so they can participate in therapy in a meaningful way with the therapist. And fortunately, we have a great DMH team, and all our kids are seen by DMH, and everybody gets screened and evaluated, and they all have an open DMH chart. And absolutely, whenever necessary, we have also a great, robust psychiatric team, I should say, and we do have competent and talented child adolescent psychiatrists who are key in us accomplishing this goal of proper and thoughtful and methodical evaluation and treatment of these youth. So there is always a process, and medication is not automatic, and it's done after a proper, thoughtful evaluation. And Dr. Fitzpatrick will be talking about the process a little bit. But one other thing I want to emphasize is that medications are not just, it's not a knee jerk in our juvenile justice settings. It's like something that is done, even if it's a sleep medication, because I know the sleep medication topic keeps coming up. A lot of times, I must say that sleep is an important component, and a lot of these youth have been in the communities, they've dealt with trauma, a lot of trauma, and they do need, because it's such an important vital function of the body and the mind. I think it is important for them to have a restful sleep. And we do, even there, we usually try non-medication techniques first. For example, sleep hygiene, relaxation, and those things before a psychiatric referral is done. A psychiatrist sees them, evaluates them, and offers medication. And and the types of medication that we offer too, in generally, are we usually use medications that are safe, considered safe, and that have low addictive potential. And that's just to give you a brief overview. And same thing goes with substance use disorders, which is another very key topic. Even there, we do have psychosocial non-medication approaches. Dr. Fitzpatrick is going to talk about those, address them a little bit. We do have things like motivation interviewing. We do have cognitive behavior therapy, ability to do that. We do have seeking safety and some approaches that are very effective, especially in the context of substance use. But whenever it becomes necessary, whenever it's indicated, we do offer medication-assisted treatment, mainly for opioid use disorder. But MAT is not just for opioid use disorder. We have medication-assisted treatment, for example, for tobacco use disorder, or we could have medication-assisted treatment for cannabis use disorder. I know it's far more documented, and there's a lot of literature more for opioid use, but we do have that ability and that bandwidth to be able to offer that to the youth both in the juvenile halls, our camps, and Dorothy Kirby Center. So I think, but I must say that we see a lot of variegated diagnoses. And you mentioned the number with CDC. Yes, you're absolutely right, Dr. Kongora. The percentage of youth receiving medications is higher in the juvenile justice settings, but also the diagnoses. For example, if mental illness prevalence, last I checked, was if it's around anywhere in the 15 to 20% range, it tends to be upwards of 70% if you look at national statistics. I mean, I must say, over the years, the total juvenile justice population has decreased, but even with the population that we see in juvenile justice settings, the acuity of the mental health conditions and substance use, which, like I said, we need to address both, that has definitely not decreased. There is a significant amount of that continues to persist. So having said that, I want to pass the microphone to my colleague, Dr. Fitzpatrick, so he can talk a little bit about the process, how we go about in the juvenile justice settings. He'll walk us through from when the youth arrives and take us from there. Thank you, Dr. Fitzpatrick.
Thank you. And to dovetail on what you just said, it's not a knee-jerk reaction to start medications. There's a process that people go through. And that starts from when the youth is first detained. The probation does their own intake screening, which includes, which is of interest to us because it includes things like history of mental health treatment, hospitalization, current suicidal ideation, hallucinations, any medications that they might be taking, grief, gender identity, sexual orientation, substance and alcohol use. Right after that, and this is the very beginning, no matter what time they come in to the facility, the nursing does an intake, and that includes all the medications that they might be taking at the time. They also do vitals. They look for symptoms of withdrawal, history of substance use. They contact the parent or legal guardian to get more information and details about any medications that they might be taking. And then if they're on a psychotropic medication, they'll call an on-call psychiatrist, which we provide 24/7. And to continue the medications, it's called continuity of care. And we do a 7-day supply, but we usually have a psychiatrist do an evaluation within the first day or two if they've been taking medications, psychotropic medications in the community. The next that happens in NLP, I think the average is about 24 hours later, but can be up to 2 days later. The mental health clinician does a complete psychosocial assessment, reviews the 2 electronic health records, the one that the DMH uses in general, and our own probation electronic health record, contacts the parent or legal guardian for additional information. They do something called a MASI, which is a screening instrument for things like anger and depression, and they do a scale of that. They do a co-occurring disorders assessment, which is a comprehensive substance use assessment. The parent and caregiver are also given a questionnaire about substance use. And there's also a co-occurring substance use child screening instrument, and they do a Columbia Suicide Severity Rating Scale. A complete physical is also done, which helps inform us as psychiatrists as well, within the first 2 days of being detained. A psychiatrist, they refer to a psychiatrist for several reasons. One, if they have some sort of major mental illness that might be helped with medications, and another is, or if they're experiencing suicidal ideation, history of hospitalizations, or are currently taking medications, or if something comes up during the course of their detainment. They may not have these symptoms when they first came in, but they develop it over time. For our psychiatric assessment, we do a chart review, interview the youth, the parent, legal guardian, get a history of the chief complaint, whatever they came in with or what they were referred for. Any symptoms identified in the assessments, any history of that, history of medications, history of psychiatric hospitalizations and or treatment. Family history of mental health diagnoses or treatment. We take a social history, we do a developmental history going from the pregnancy to developmental milestones, any history of diagnoses of things like autism or intellectual challenges, specific learning disabilities, any history of that. We do a mental status exam and then formulate a diagnosis based on the DSM criteria. We put together a care plan. If a medication is indicated, we use practice parameters established by a committee in Los Angeles, but also used throughout the state. So we follow those guidelines when we prescribe. We get a written consent which goes over the side effects of the medications that we are proposed to be given. We get consent from the parent, legal guardian, and also the youth. If the parent or legal guardian are not available, or if they're under DCFS, we'll go through an application to the courts if we are thinking about starting a medication, and that's reviewed by a child and adolescent psychiatrist and a pharmacist, and recommendations are given to the court of whether or not this is an appropriate medication, matches out parameters, etc. We also schedule a follow-up appointment and do something called a Columbia risk screening at every visit. When medications are given, nurses will ask every time they dispense the medication, and the nurses are the ones that dispense medications in all the halls and camps. They ask about side effects each time. When they visit with us, we also ask about side effects, positive effects, and overall well-being during our assessments. One of the requests was that we go over the classes of medications and side effects of particular medications. So let me go over those real quick. It's not going to be very comprehensive just because we don't have that much time, but I'm going to go over a few of the medications and common medications that are prescribed. So the antidepressants, they have names like Prozac, Zoloft, Wellbutrin, Trazodone. There are about 17 total antidepressants that we can choose from. There are older antidepressants that have a lot of side effects, so we steer away from those and go to the more newer antidepressant medications. We choose it depending upon their history of medications, or if there's a family history of using psychotropic medications, we might factor that into our decision making of which medication would be best. And the side effects are mostly GI side effects, stomach ache, nausea, diarrhea, those types of things. Weight gain or weight loss, sedation, sometimes decreased libido. Can also be used. These medications are sometimes even used for anxiety disorders like obsessive compulsive disorder, generalized anxiety disorder, and can also be used as an adjunctive treatment for a post-traumatic stress disorder. Some adverse side effects include serotonin syndrome, priapism, and rarely suicidal ideation. For the stimulants, they're for ADHD treatment. Common names are Adderall, Vyvanse, Ritalin. Most common side effects are decreased appetite and difficulty falling asleep. They can also have a side effect of stomach ache or headache. There are other ADHD treatments that are non-stimulants, including Strattera, Clonidine, Tenex, and Wellbutrin. Those can be sedating. Wellbutrin can be activating, increased anxiety and increased energy. It's also used as a MAT for smoking cessation. There are the antipsychotics. Common names are Risperdal, Abilify, Seroquel. They're used in psychosis, but can treat bipolar disorder, aggression, and they're used in Tourette's disorder. Side effects, most common are sedation, headache, stomach ache, weight gain. There's a rare adverse reaction called tardive dyskinesia, which is kind of a movement disorder. If we notice that, we reduce or stop the medication, but there's a certain percentage of folks that the tardive dyskinesia may continue. There's also something called dystonia, which is like a muscle spasm that people can get. That is not a permanent. We also have to monitor for diabetes and increased cholesterol with the antipsychotic medications. There are the mood stabilizers, lithium, Depakote, Lamictal. They're used in bipolar disorder and schizoaffective disorder. The side effects are weight gain, GI side effects, stomach ache, nausea, diarrhea. The adverse effects include lithium toxicity, which includes like an altered mental status, kind of a delirium. We have to monitor for hepatotoxicity, liver problems. So we frequently do blood tests to monitor this. And also look at the blood levels of lithium and they call it valproic acid to see if we were in the therapeutic range. There are antihistamines and hypnotics. These are probably the most common medications that we prescribe, things like Benadryl and melatonin. And those are the same as the over-the-counter Benadryl and melatonin. They're not prescription, but the psychiatrist is the one that manages it. Mostly because there's a lot of mental illnesses that have insomnia as a side effect. We also prescribe a little bit higher than the population that's outside of detention, which makes a lot of sense because folks in detention are under a lot of stress, away from their families, worried about the next court date, that sort of thing. And just being detained itself is a stressor. There are the anxiolytics, which means, side effects of those medications are things like dizziness, headache, stomach ache, sometimes dry mouth. There are anxiolytics, which we rarely use just because of the addictive potential of these medications, but they are sometimes indicated for things like alcohol withdrawal, which can be life-threatening. So we have to use these types of medicines for that.
Just to clarify, Dr. Fitzpatrick is talking about the benzodiazepines.
Yes.
Yeah, perfect.
Yeah.
Go ahead. You can.
I'm sorry?
Oh, what was?
No. When you said anxiolytics, you were
Anxiolytic
talking about
benzodiazepines, yeah.
Just want to clarify that.
Yeah.
Sorry.
So those are medications like Ativan and Klonopin and Xanax. They're used for anxiety, insomnia, and withdrawal. Their most common side effects are sedation and dizziness. Sometimes the pediatricians will prescribe these medications, the benzodiazepines, if somebody's going through withdrawal. There are other anxiolytics, anti-anxiety medications that are non-benzodiazepines, not addictive, like Buspar and gabapentin. They're usually used for anxiety and aggression. Side effects, again, GI symptoms, stomachache, headache, nausea. And that's it for the.
You might want to mention about MAT medications.
Do you want to go over MATs?
Sure.
Thank you.
Sure, thank you. So I just want to briefly mention, dovetail on Dr. Fitzpatrick's presentation of various meds, that we also, after a detailed evaluation is done, the MAZE is completed, psychosocial eval, the psychiatrist has seen them, say during the course of their evaluation, the psychiatrist realizes that the youth has been using opioids. And it's been a constant problem. It's been, which includes many of the drugs of abuse, opioids that they abuse, including heroin. These days, fentanyl can be very life-threatening, and we know that about that in the news. I mean, so many overdoses, even in our juvenile justice system, unfortunately. So sometimes it presents as withdrawal because they just come out and then they have withdrawal symptoms, and the nurses actually pick it up, and then pediatricians and psychiatrists could be involved. And we work in a collaborative manner to treat the withdrawal symptoms. But one thing is, we want to be cautious. We definitely are on the side of caution. If the withdrawal symptoms are serious and severe, then we do would prefer to send them to the emergency room so they can be stabilized, and to make sure that, and definitely probation in the facilities they do have access to Narcan, naloxone for if there's any immediate overdose. I just wanted to make that clear distinction that we do have to intervene first. And then, yeah, we do err on the side of caution to make sure that they get sent to the emergency room if we feel that it is the acuity is very high. But if it is on the moderate side, if it's manageable, the withdrawal, then both JCHS and us, DMH, in collaboration, will treat the withdrawal symptoms. And in many situations, the youth is interested in continuing medication treatment, so they are able to help their addiction issue or their substance use, opioid use disorder in this case. In those instances, our psychiatrists are trained and they will be, they are able to prescribe medications or the MAT medications, which is the medication-assisted treatment. And the most commonly used one is Suboxone, which is a combination of buprenorphine and naloxone. And it definitely has, it can be life-saving in many instances because it is known as partial agonist in that they don't get the same high that is produced with opioids. So that's a medication that is very commonly used. But there's also longer acting versions of Suboxone, which are also used in our juvenile facilities when it is clinically indicated. And in fact, Dr. Fitzpatrick has used those more recently. And those are known by common names Sublocade or Brixadi. And they're both very effective. The advantage with them is that once you administer those medications, they last in the system for much longer period, several weeks to a month. So I think that can be advantageous, especially, but this is done with definitely with the youth's consent. Now there is a new law in place for MAT. Governor Newsom signed the law, but I think went into effect 2023, if I'm not mistaken, where a youth 16 and above can consent to their MAT, especially if it's Suboxone or buprenorphine containing medication. So that's I think could be a potentially a life-saving type of a law, and our psychiatrists are aware of it. We do have regular psychiatry meetings where where we have an avenue to discuss these types of changes or legislative initiatives, so they are educated and informed about these things. And in some instances, youth can also receive MAT with an opioid antagonist, as in when they're very sober, and I'm referring to Vivitrol or naltrexone. It's not a partial agonist where the ceiling effect is limited. Here, this is actually an antagonist to, in other words, if these youth are taking the Vivitrol or the naltrexone, then if they were to accidentally abuse opioids, they would run the risk of having withdrawal. So that's another thing that we have done in our facilities, but it does require, the patient or the youth must be motivated. And we, of course, our psychiatrists are really good about educating the youth about the benefits, risks, side effects, adverse reactions. And that's the reason we are here today to talk about those things. And most definitely, even though there is laws that 16 and above a youth can consent, as much as possible, our psychiatrists try to involve the parents whenever there is a parent available or caregiver, because it definitely leads to better outcomes when the family is involved. There is a caring, a loving one that encourages them to comply with treatment and such. So to that end, we do have various forms of consent, which we get consent in every case. But if parents are available, we can get a witness telephonic consent. And I know Dr. Fitzpatrick has already talked about the court authorization. So in addition to the opioid use disorder, we also have some treatments for cannabis. There are some medications like gabapentin, which we talked about, which can be sedating at times, or for that matter, we also use N-acetylcysteine is another medication that is gathering some momentum. And then we also have tobacco use disorder medications, whether it's bupropion or the Nicorette and other medications. So I think Antidepressants like bupropion can be very useful in tobacco use disorder, which Dr. Fitzpatrick mentioned. So I think overall, compared to where we were, one thing about MAT in youth is I would just want to mention that MAT has been evolving for some reason in the last 7 to 10 years. It was not because these were medications that were off-label because they're mainly used in adults, Suboxone, buprenorphine. But there is a lot of momentum throughout the country because of the advent of opioid use disorder and fentanyl overdoses and all the adverse things that have taken place. There has been a definitive and a thankful momentum that has been provided. And I'm glad in LA we have definitely embraced that momentum to offer MAT whenever it's clinically necessary, whenever it's clinically indicated, and be able to prescribe, have the necessary expertise to prescribe and to continue and also provide aftercare. To that end, I would be remiss not to mention SAPSI. SAPSI has now a footprint in the juvenile justice settings, and it's been very collaborative, I must say. And our DMH colleagues, they collaborate with SAPSI, and even though we do have an aftercare program, which I mentioned earlier, the
Dr.
juvenile
DeMarla,
justice,
can you just say what SAPSI stands for?
of course, Substance Abuse Prevention and Control. It's a division of DPH, Department of Public Health, and they have been very able and capable partners. So in a way, there's a little bit of redundancy in that we have an aftercare program, which I mentioned earlier, JJ TOTS, Juvenile Justice Transitional Outpatient Treatment Services, and SAPSI also follows them in the community, and also they also have a footprint in the juvenile justice settings. But this redundancy is a good thing. Like I know we talk about having redundant systems in airplanes, just like that here too. I think having something to fall back on, where you have DMH and SAPSI both working hand in hand, so we can prevent as many adverse outcomes as possible. So that would be a few points about MAT and substance use that I make. Go ahead.
Yeah. Now, Nate, the other point is that sure. Yeah, naltrexone is also used for opioid cravings, and that's the main reason why we use it in our halls and camps. Closer, sorry. Okay, got it. Oh, yeah, opioid cravings. Naltrexone helps with opioid cravings. Yeah, and naltrexone. Yeah.
One of the medications that I mentioned earlier.
Yeah. I also want to go over the consent process a little bit. There's the physical consent of when the nurse gives a medication to a youth. They're consenting to take the medication. But before that, we go over the side effects with the youth and the legal guardian or parent. We get either the witness telephonic consent signed, which is we go over the side effects with the youth and the parent or legal guardian, and with a witness that listens in, and they sign as well that we've went over this. There's also the outpatient medication review, which is a list of side effects, and if somebody's 18 or older, they sign that. The parents don't necessarily have to be involved in that particular consent process, but we, of course, encourage the family to be involved. And I also want to go over a little bit about partnering with the DHS pediatricians and nursing. There's actually...
Excuse me,
think
I
that's a
don't mean to
question.
interrupt. We just have one question over here.
One question about consent. What if there is not consent by the parent or guardian? If kid's 15, I don't want my child on medication, what do? Take it to the court?
Yes, so we'd go to the application, psychotropic medication application. If we feel strongly that this person really, like somebody is depressed and suicidal or psychotic, we would go to the psychotropic medication application. and then the courts will decide and either approve or disapprove the medication.
And thank you, Commissioner Harris, because Dr. Gongora, if it's all right with you, there's been a lot of information provided so far. And so I'm wondering if we could just take a moment for the commissioners that might be having some questions before we move on, just because there is so much. One question that I have is, do you have a list that we can have access to of the most commonly used medications? I know you mentioned gabapentin, and some of the side effects of gabapentin is depression, anxiety, suicidal tendencies, and so just if we can get a list, that would be really helpful too, because you've put so many different medications out here. And if I'd like to turn it over to the commissioners for questions, please, if you will.
Sure. If you don't mind, I just want to add to what Dr. Fitzpatrick just mentioned, or if the commissioners want to ask a question first, I'm fine with that too, either way.
Can you hear me? Is this on? Okay. So our parents, is there education around like alternative treatments? Or is that education provided to parents as well as the youth? Do they have time to think about it? And is there even education around things like the side effects or the even stigma? Because there's so much stigma, especially in our communities, around using medication. So I'm just wondering who's there to kind of help parents and the youth sort through that. These are such big topics and decisions.
What we do is when we think that a medication might be indicated, we contact the parents not only for consent, but we also give that type of education. And most of these medications don't work as well if we just give the medication. They have to have other types of treatments as well. There's some diagnoses that therapy alone is helpful. So what we do is we give them the information. If they're hesitant or want more information, we provide that, but also give them some time. Say, if you want to get back to me next week and we'll decide whether or not this medication is right for your child. Talk to other people about it, get information on the internet, which is always kind of a little scary. But bring that stuff to me and ask those questions, and then together we'll decide whether or not a medication is the right fit, or if you want to try a lot of people try therapy first for things like depression, which can be very effective. Yeah, we do provide that information.
And then I think you said there are certain instances where youth age 16 can consent to things. Is that the same as youth who are not inside facilities? Is it the same age? 16-year-olds can consent to certain treatments without parent consent?
Yeah, it's only the MATs with buprenorphine in it. So that was a statute, a law. So that's the only case, and I think they have that because there were a lot of fentanyl deaths, and a lot of the youth did not want to disclose to their legal guardian or the family that they're suffering with this addiction. So the idea is to prevent these kind of deaths. Counseling in itself it doesn't need permission from parents, but medications do, except for this one buprenorphine.
Commissioner Jackson.
Yes, thank you for your presentation. Are you guys able to provide a specific but anonymous example of a case where you evaluated a youth, the screening tool that was used, as well as how it was determined that MAT would be the most appropriate response to that young person, as well as with emphasis on the ongoing monitoring that results from that process?
There's several screening tools that we use, including the co-recording disorders assessment, which is the most comprehensive because it gets the entire kind of history of substance use. And we also ask the parents, because they often know, like if somebody had an overdose or wound up in the ER in the past, the parents would know that. And the youth might not necessarily disclose that to us for various reasons. Maybe because they're in the juvenile justice setting, they're afraid they're going to get in trouble for it. So it's not a one-time thing. It has to be an ongoing kind of process. Once you develop a rapport with the youth, they're more likely going to disclose those types of things. We also do a parent caregiver questionnaire, which is kind of a standardized questionnaire, and a co-occurring substance use child screening instrument. So those are the kind of standard screening instruments. But I've always found the most helpful is the co-occurring disorders assessment, because it gives much more detail. What the youth have been using, when did it start, how often they were using it. Whereas the screening instruments will just be that. Have you ever used any of these recreational substances or alcohol?
Those are more generalized. Do you have a specific example of a case that you guys followed, like entire life cycle? I'm curious about the use of medication, and do you guys perceive it as a means to an end? Like once a young person is on medication, how are you guys closely monitoring how they're responding to it, how effective it is? And ultimately, I would imagine that if the goal is to create some balance, assuming that there is some imbalance there that the medication is intending to address, at what point do you guys decide that this thing has served its purpose and we can discontinue use of it?
There's certain guidelines that we use, like for antidepressants, it's usually around 9 months of being on an antidepressant, then slowly decreasing and stopping it to see if they still need it. So we do it in kind of a methodical way so that they don't go back into a depression by decreasing it. For substance use disorders, we look at acute, meaning that somebody comes in and that they say going with withdrawals. We might start a buprenorphine product and then wean them off of it. It's a big red flag, though, because we have to look at their history closely to see if they make criteria for an opioid use disorder, for example. And if they do, then we might continue with maintenance therapy or treatment of a MAT, which is more long-term. We also make sure that once they leave this facility, that they have aftercare, so that they continue. If they wish to continue with the MAT, they'll be able to continue with the MAT. While they're in the facilities, we see them once a week for follow-up. What's working, what's not working. Do we have to adjust the dose, that sort of thing. There's a tenet in child and adolescent psychiatry is that we usually start at a lower dose and kind of work our way up as clinically indicated. We kind of know the dose ranges that work for most people, so that becomes our goal. Did I answer your question?
Somewhat. I mean, for the most part, yes, and I do appreciate that. I'm also curious about the diagnostic patterns. It sounds like in the beginning of the presentation, you guys suggested that the rate is very high. I'm wondering how many youth have pre-existing diagnosis that's prior to incarceration versus those that are diagnosed in custody.
Did you want to?
Sure. I think there is a significantly high rate of diagnoses of all the disorders relative to what it is in the community. Now, is it the chicken or the egg has always been a question, and we look at it in a more comprehensive way, in a detailed way, to see when it started. In many instances, for certain conditions like ADHD, the youth has, in many cases, we get information from the parents and the youth themselves that they've had ADHD from the very beginning. And unfortunately, they did not get the proper treatment for it, or they took medication for a while, then they stopped the medication. And same thing with other behavior disorders, like a conduct disorder, oppositional defiant disorder, that they always had it from their very childhood, as long as their memory goes back. And the parents corroborate that information. With things like depression, there's a great point you made. Sometimes youth can be very dejected when they come into the juvenile justice system, and they may be going through a serious adjustment once they're in the facilities. So I do give credence to what you just said, that but we do have to tease that out, whether it's something that because they got bad news from court, or is it because something's going on in their family life, something's going on the outside, because of which they are going through a severe state of sadness and other depressive symptoms. Because if it's adjustment disorder, which is usually a reaction to a situation, something that's ongoing, then more likely than not, that could subside or get better. It could ameliorate or improve with time, provided they have the necessary support from clinicians. And even if the psychiatrist is not prescribing medications, sometimes the psychiatrist will still see them and to see how things are going. And we do go through the consent process, like I said, talking to the parents and to the other commissioners' query, Ms. Terry's query, Commissioner Terry's query, that we do talk about alternatives with parents. That if this is something that only started during the detention, that the youth is very so. We do give the benefit of doubt, and we give the parents some time for them to think about whether they want their child to take medication or not, and we talk to the youth, the child themselves, to see if they want to take medication. So, but the conditions such as ADHD, which is one thing that I mentioned, the other situations are like things like bipolar mood disorder and certain other mood-related and mood and behavior disorders. There's some conditions like disruptive mood dysregulation disorder. It's also called DMDD. It's a relatively newer diagnosis, but I have seen that to be present in the juvenile justice settings. It's also there in the community, but it's a little bit on the higher end, percentage-wise, in the juvenile justice settings. Now, those the mood disorders and the DMDD, which I mentioned, they tend to get significant benefit along with other modalities of treatment, that is therapy and other things, when they get started on medication as well. So I think it's a careful approach. We do look into how they are doing on the unit, talking to the pediatrician, talking to the therapist who's dealing with them, talking to the caregivers, the parents, whenever they're available. And we base our decision on the basis of many factors. And definitely, like Dr. Fitzpatrick mentioned, past history, like a history of hospitalizations, history of medications. And some of these medications, like he alluded earlier, like antidepressants, if it's a first episode of depression, it's possible to potentially discontinue them, say 9 to 12 months later, if they're doing well. But I think certain conditions like ADHD and bipolar and psychotic disorders like schizophrenia, they tend to persist much longer, sometimes lifelong. So in those instances, it's also our place to educate, inform, and work with them collaboratively with a good rapport with the family and with the youth to educate them that you're going to need this medication long term. So I think it cuts both ways. And we have to be very thoughtful about it. And the same principles we apply when it comes to MAT. Like if it's been a on and off relapsing opioid use disorder. And yes, they went through withdrawal, but during our subsequent evaluations, we found that Suboxone is necessary for maintenance, and the youth is taking it, and there's a possibility that the youth might relapse again, then we would encourage them to go ahead and continue to take Suboxone even after they get released. And it's definitely our role to provide them with the necessary follow-up in the community. Do you want to add?
Thank you. Yes, Commissioner Harris? Oh, go ahead.
I have a follow-up question. This is my last one. And
Okay.
part of my question came from wonder and some worry, to be honest. I think that making assumptions about community conditions in the background of the young people that we serve makes it easier to try to justify the prevalence of certain things, or well, not the prevalence, like the diagnostic patterns, right? But I also worry about maybe the misinterpretation of symptoms. I worry about overdiagnoses. I worry about misdiagnoses, you know what I mean, and the detriment that that poses to young people while they're incarcerated. Yes, medication feels important when there are obvious disorders that it can address, but I have personal examples and experiences of kids that just did not need to be on medication, and that prescription exacerbated a condition, right? And we really need to be teaching kids how to cope with things in a sober way versus resorting to medication, especially when once they're released, it's something that they can't really adhere to. So it sort of adds insult to injury when they're sort of exposed to really raw conditions without the proper supports.
Yeah. Yes, Commissioner Harris. Oh, go ahead.
Yeah, you're absolutely right. We tried our best to make the most accurate diagnoses and make a treatment plan based around that. Medications are often a last resort in a lot of these diagnoses, but there are other ones that, like psychosis, for example, that medications can be very helpful, and that we do need to kind of start early on if we can. Same thing is true with mania. So, but you're right. The other support is needed, and like I said before, sometimes we could use just different types of therapies rather than medications. So we're
Thank you, Commissioner Harris.
It doesn't sound like it.
okay. Yeah.
I got the Commissioner Meredith disease over here. Dr. Gongora said that 9.3% of youth 15 to 17 in the US have some sort of diagnosed mental health condition. Do you keep data? And if so, you just said there was a significantly high rate of diagnosis compared to youth and community. What is the rate of diagnosis of youth with mental health conditions? And to echo Commissioner Jackson's question, what is the percentage, if you keep that data, of youth who come in with an identified mental health diagnosis, and what percentage is identified in the hall through your team? And then secondarily, the same data questions for youth on medication who come in, prescribed medication, whether or not they're taking it, but prescribed, and then what's the rate of prescription in the facilities? If you have, you may not have the data. Do you have access to the data? Could you get it to us later, or could you tell us right now?
We have some data. We keep track of medications, and we do a report. And we do audit all our kids on consents. And I must say, there is a higher rate of diagnoses across the system in our jurisdiction in LA County and nationally as well. It's unfortunately it's 3 to 4 times more. And I would say, in respect to facilities, I think in some of our juvenile justice detention facilities, the rate of medication is higher. For example, at Dorothy Kirby Center, we do have a higher percentage of kids on medications. If you look at Los Padrinos Juvenile Hall, the rate is lower. It's definitely not 9.3. It's more in the 30s with LP, with our recent data. But when you look at Dorothy Kirby Center, where the youth are higher acuity, it does go up to 60% or even higher when it's there. And I think our relative rates with the Campus Vernon Kilpatrick 2, where the girls are being housed currently, is on the higher side. Similarly, SYTF, which is the Secure Youth Treatment Facility in Selmar, the rate is higher. Not as high as Dorothy Kirby, but it could be in the range of 50 to 60%. We also keep track of antipsychotic use, and I know that that was a big point of contention, and there are some places where antipsychotic use in the country, there was concerns that it was reaching 50 to 60%. Now, when I say there's 50 to 60% of youth taking medications, that's not antipsychotics. That's inclusive of all medications. But our antipsychotic use, though, I must say, is much lesser. It's, for example, in some places, it can range anywhere from I would say 10 to 20%. In fact, Dr. Fitzpatrick, so recently you did the data too. It's typically around 10 to 20% compared to sometimes the red flags that were raised in the past, that antipsychotic use as well as reaching like 50%. That's not where we are. Fortunately, we are very cautious. Our psychiatrists are, where they are very mindful to make sure that, because the antipsychotics have long-term side effects like weight gain, metabolic syndrome, diabetes. If and when we prescribe those medications, we make sure there's proper labs that are done. For example, glucose, hemoglobin A1C, there's a test for diabetes, a fasting lipid panel, and those are not just in the beginning, but we also, if the youth stays long term, then we try to monitor them every 3 to 6 months, depending on the clinical need. So all those factors are taken into consideration, and there are times when we collaborate with pediatricians to make sure that other tests, so say for an EKG if it's necessary, or any outside referral for any cardiac concerns or any neurologic issues, say seizures, those are also followed. So I know time is of the essence, but
Thank you very much. We do, yes, Commissioner Meredith, this is going to be the last question, though, because then I also have a question, but Commissioner Jackson and Harris touched on some of the things. Go ahead.
Yeah, this is all Greek to me. So I'm looking for a simple term of roughly in custody, do we have a percentage of how many people have mental health issues and how many of those percentage-wise would be on psychotropic drugs?
sure.
About 60% of those detained, and it's not only in our facilities but nationwide, have some diagnosable mental illness. And it varies among the facilities, but about 20%, say in Los Padrinos, are taking some medications. Vast majority of those medications are sleep medications, and that's understandable, because you come into a facility, you're away from your family, you're not in your own bed, it might not be the most comfortable, you're worried about the next court date.
Or mental depression.
Yeah, yeah. And so there's a higher percentage than, say, the general population and the numbers that you gave at the beginning. So that's the reason why.
Thank you so much for that. And that's, something that raised concern. We did have a presentation by UCLA on the brain activity, and being the conditions of confinement, with the gray walls, the cells, lack of sunshine, of course, disconnected from your family, community, human touch, exercise, all of that would, in fact, according to that study, increase environmental depression. And I think that's why there's so many questions as the data on youth that did not have this prior to entering the facility. And one of my questions is, do you have data on youth that are on multiple medications? I mean, you have listed so many medications. So I am requesting a list of all medications prescribed for mental health to the youth, and also data on youth that are on multiple medications. Do you have that?
We do, and we actually gave the last one to Ms. Gluckman. So we're planning on doing that quarterly and presenting it to.
Okay.
I just want to add that Judge Nash, who was officer who retired recently, and actually I'm so glad Ms. Gluckman reignited that effort. That we sent her the most recent stats, and we're going to continue to do that. We keep track of how many youth are on one medication, 2, 3, 4, and so on and so forth.
Yes, and then also if you have data on, you say that, they are of age of consent, or that sometimes the parents do not consent, and then you will file it in court to override the parents. Do you also have data on that, on how many times you've overridden the parents' decisions?
Yeah, this document that we sent has information about that too, as to how many youth had witnessed telephonic consent versus court authorizations.
Age. And age.
Chair Canales, if you perhaps Ms. Gluckman can address some of those issues. And also, for those of you who don't know, Stephanie works for the
Office of Child, Youth, and Family Wellbeing. Did I do that right? Which is the organization that used to be known as Office of Child Protection, OCP, which is in our office, the executive office. So Stephanie and I are colleagues. So I think we can work together to find a way to share that information directly with the commission in a way that is educational and helpful to help you understand it and to address those issues. But I don't want to step on your toes, Sarah, but maybe Stephanie can make some comments.
Is it time?
Yes, it's time.
Can you all hear me? I come to you all from across the world in Botswana right now. So thank you for having me virtually. And thank you so much to my partners at the Probation Oversight Commission and to my partners at DMH. Dr. Demerla and Dr. Fitzpatrick, we have been working together for many years now, and I think have done some good things together. Just to let everyone know, the Office of Child, Youth, and Family Wellbeing, we are a strategic hub for advancing child and family well-being policies. We align systems, support upstream prevention, and advance policy and systems change. So essentially, we work across departments on policy and systems change. And so what you will hear from me, because that's my expertise in all of this, though I have a learned expertise in the substance use and psychotropic medication area, really my expertise is how do we change systems based on what we've been observing. So I've been working for over 3.5 years on substance use disorder and a youth opioid response work, and on increasing access to MAT for system-involved youth. And my office, as Dr. Demerla mentioned, through Judge Nash, also looked at psychotropic medications for system-involved youth for many, many years. And what's interesting about this is that sort of the goals of these two things have been opposite. We've been trying to increase access to MAT for youth, while we've been really trying to look at and control any overuse of other psychotropic meds. So though there have been improvements throughout the years, what we've been seeing recently and a little bit in the data that I just saw is there's been a little bit less prescription of MAT than we've seen in the past few years. But as Dr. Demerla and Dr. Fitzpatrick said, quite a large number of youth on sleep aids. And though I think this is, medically, clinically necessary, as they opened with, these medications are part of the solution, not the entire solution. And I think with all of this work, in order for us to get to the entire solution, we need cross-departmental work, but most specifically, we need probation as our partners at the table to work on this. An example is Dr. Demerla spoke about sleep hygiene, and whether that's, darkness or quiet or exercise or sunlight, all the things that, and there are many more on that list. I think, DMH, if you're in therapy and you're taught about these things, we need probation as our partners to implement these things. So I think as we look at our successes and our challenges, my main message here today is how do we get probation at the table as much as possible to work with us? And when we look at the work that we've done for the past 3.5 years on medication-assisted treatment for substance use, we have had great accomplishments in increased screenings, increased treatment, updated trainings, updated policy, youth engagement, improved data collection, and one of the biggest achievements we've had probation there only on and off at the table with DMH and DHS and DCFS and DPH SAPSI, as Dr. DeMerla spoke of earlier. We've all been meeting, every 2 weeks for many years, and probation has only been there on and off. When probation has been at the table, we've been able to do great things, such as we were able to get a vending machine placed outside of LP with harm reduction products in it. And it is now the most used vending machine with Narcan and fentanyl strips and all the life-saving things. So we've been able to accomplish some great things. We are still working on updated policies and trainings and many other things that we need probation's participation for. And currently we don't have anyone from probation at the table. So whether it is with respect to Matt or with respect to addressing sleep aids in particular and really trying to focus on the non-medicine, non-medical approach through sleep hygiene or many other issues with psychotropic medications, I think in addition to the questions that we are asking, which are all valuable, it's how do we get probation at the table as our partners to work cross-departmentally on policy and systems change.
Thank you so much for that, Mrs. Gluckman. And I am happy to say that there's a familiar face at the end of the table to many of you today who is here on behalf of Probation, Director Catherine Bay, who is here today because of her experience in facilities and currently working at Dorothy Kirby Center, but also deep experience with the LA model, formerly superintendent at Campus Kilpatrick, and the opportunities to understand what it's like to do the day-to-day supervision with youth who are using for the positive and side effects issues, psychotropic medications. And maybe, I don't know, Ms. Bay, whether you're prepared to answer the question about the attendance at the psychotropic medications work group. My thought is maybe not, but if you are, then great. But if there's anything you'd like to share, and also she's here to answer your questions about how all of these issues impact the daily operations for supervision.
Yes, thank you very much for asking probation to join this panel. So our role, I was really happy to hear Dr. DeMerla in his very first sentence use the word suffering, because we do see young people in the facility suffering a lot with their behavior. And our role in probation, obviously we're not the medical side or mental health, although we're trained in some of those things, obviously not to the degree as our partners, is to support young people in their treatment and rehabilitation. And so if they have decided along with their family and medical that they are going to take medication, it is our job to make sure that they receive it when they're supposed to, safely take it. And we also are able to, we've worked on it and we do, I think, a really good job of, we don't need to know the diagnosis of a young person or the medication that they're taking. What we support and help with is, what are the side effects that they may have that we can support them with? Over the years, the medications have, as both doctors said, improved, but I remember a lot of the side effects used to be kids couldn't go in the sun. They had to have more access to water. They might get dizzy. We still are very clear on which medication will make young people more sedated or sleepy, so that we make sure that medication gets to them right before they are going to go down for the night, so that there's no harm that would come to them from being sleepy, right, and still moving around. So most of our collaboration and direct contact is with the nurses that are providing the medication to the young people, and they will let us know if the medication has side effects that we could support the young person with. We also have rapport with our young people, so they will talk about that they're taking medication, and we ask them if there's anything we can do to help them. It's our contact with psychiatry directly isn't as much. We usually do it through mental health or JCHS, but I can just recall, it's been many, many years I've worked directly in facilities of the last 9 of 11 years. And the medication, the MAT, that kind of treatment for opioid or young people that are taking, were taking drugs in the community was a new one for us. So we had to be educated on that in the last few years, because those side effects were a little bit different and we needed to have more information on that. But our partnership with nursing, I can just remember even sometimes certain medications are time released, or so young people have to take it multiple times a day. We've worked together on like, some medicines you cannot crush, right? Some medicines have to be dispensed that way. So just having all these are just examples of all the conversations that we have without actually having to be a part of knowing exactly what our young people are taking or their diagnosis, and just supporting whatever they need.
Thank you. Dr. Gongora, shall we move on to commissioner questions now? Okay, commissioners. Yes, Commissioner Kakani.
I just want to get back to the sleep aids part, because I think that was really at the root of why I had asked this to be agendized at the last meeting. And I think it's just important to acknowledge that, right, like we are placing young people in a facility that, you know, requires lights to be turned on every 15 minutes, or I'm sorry, maybe the lights are on the whole night. So obviously there are challenges sleeping, as you said, being in a bed that's not your own, being in a space that, you know, you're kind of trapped in until someone decides to open the door for you. All of that, I imagine, is slightly triggering, but I think you might have said that melatonin and Benadryl are used as sleep aids. I guess, I mean, that's always struck me as problematic, that we're using Benadryl to support with sleep. And especially all of the research that's coming out now as it relates to the use of Benadryl, and that it should not be used for a period like longer than 14 days as a sleep aid. And yet I'm hearing of young people who for months on end are taking 75 milligrams of Benadryl at night. That's more than even an appropriate use for an adult. So I'm deeply concerned about that, and our reliance on Benadryl to assist with sleep, and like the extent to which you all are tracking that. And I know you mentioned, Ms. Gluckman, the increase in use, but I'd love to have some more specifics on just the number of young people that are given Benadryl, and whether that is discussed with parents, because it is, as you said, an over-the-counter medication. So are you sharing with parents that we're going to be prescribed or whatever, giving this young person Benadryl to sleep, and that these are, you know, what studies have reported as kind of concerning side effects, or do you not have to have that conversation because it is not a prescription medication?
No, we do have that conversation, and like you said, that data is kind of new. So we do share with that, and we also have the ability to give it as needed. So it's not every night. So if, say, a youth wants to stay up and read a book, they don't have to take it for that evening. So when the data kind of coalesces, we do talk about the side effects and long-term side effects of you know, extended use of Benadryl and any one of the medications that we use.
Right. If you could just share, if you can share whatever it is, the data around the number of young people who are on Benadryl as a sleep aid, and the length of time that that is being prescribed for, or made available to young people? Yes. And also dosage. Go for it.
Yeah, I just wanted to comment and clarify something. I think that given the current conditions, as you point out, I'm not saying that the sleep aids are not. I'm sympathetic to the concern about Benadryl and the long-term research about it, and all of that. Having said that, what Dr. Jamarla pointed out at the beginning, like without sleep and irritability and combined with the other issues, I'm not saying that the sleep aids aren't needed. And I think we need to focus both on the amount of sleep aids and which type we're using, but also the sleep hygiene. Like, what else are we doing? How are we creating conditions within probation, by probation, care first, where we're setting up conditions where it is more likely that the youth will be able to sleep, will be able to implement. Maybe even they get involved in youth engagement and, coming up with programs about what does sleep hygiene look like and how can it be implemented? How can, I think there's a lot of work that can be done. And if I am correct, and maybe Dr. DeMarlo, you can speak to this, I know from 2016 to 2020, there was a physician at DMH who took it on as a project to work on sleep hygiene in the camps and halls and was making some improvements. And then when COVID hit, that all kind of fell apart. So there is some history with this. And I think it would be great if we could partner with probation to work on that again.
I agree, and I appreciate that. But to your point, I've always wondered why we don't give kids eye masks at night, right? I mean, if you're going to have the light on all night, how hard would it be to give a young person a mask? Even a weighted mask probably makes it easier to sleep. But instead, we're relying on Benadryl as if it's like a necessary evil. And so I just, ask all of us to kind of challenge that thinking. And to your point, Ms. Gluckman, like, how is it that we can better care for our young folks without having to rely on things like Benadryl? But I think that data would also be super helpful, because I know it's not oftentimes considered a psychotropic medication. But yeah, my other question was related to when a young person, a psychiatrist prescribes a medication, young person says no thanks, family says no thanks, and then you all go to court and then get the judicial order. And if the young person then refuses to take that medication, is that then reported to the court as like a negative behavior or I just worry about that kind of being used against a young person, like their refusal to take the meds, or they don't like the way it makes them feel, so they stop taking it. So just curious how like use of medication or inconsistent use of medication is reported to the court.
So that's a great question, Ms. Commissioner Kakani. So I think consent is always a combination of the consent given by the parent and assent on the part of the youth. I mean, it's a combination of both. Now, we cannot force a youth to take medication. Having said that, like Dr. Fitzpatrick described in his the anecdote that he detailed, it's not an anecdote. He was just explaining how we go about things in terms of when there is a youth whose parents will refuse. We don't always, petition to the court right away if a parent or caregiver refuse. It all depends on a set of conditions. Depends on the diagnosis. Depends on the acuity. This is especially becomes necessary when the youth is getting hospitalized, being sent to the ER, and there's so much of self-injurious behavior taking place, and they're constantly on enhanced level of supervision, and there's a history of them being diagnosed with pretty significant diagnoses, and there's a lot of factors. Having taken that, in that instance, when sometimes youth is actively psychotic or having aggressive anger outbursts, it's pretty significant, then we will petition the court, especially when the parent says no. But having said that, the scenario that you described, because the family said no and the youth also starts to refuse, well, that's unfortunately a complicated situation that is not uncommon, and it does happen. And in those instances, I think the psychiatrist tries to engage the youth along with the mental health team to explain as to what the risks and the benefits and the side effects, as to why is it that we are wanting them to take medication. Just because we get a court consent doesn't mean that it's an involuntary medication order. We cannot force them by any means. That's totally different. Court is only consenting as parents patriae. In that instance, they're acting like the parent to provide consent. But sometimes we may, if the youth is deteriorating, we may have to look into higher level of care, like hospitalization, and we call it level 4 in our facilities. I mean, they get hospitalized, and we may have to advocate for them, not just go to the psychiatric emergency room, but actually to find them an adolescent inpatient unit. And unfortunately, there's a paucity of beds for children and adolescents in general, and much more so with respect to juvenile justice youth. I mean, not many hospitals take our youth. But every once in a while, with all the efforts, concerted efforts that we make, we're able to find a bed. And in a few cases, we even pursue something like LPS conservatorship, if the situation on an outpatient basis, obviously. That's not like in adults where it's very common. It happens, though. And once they go to the hospital, though, there have been instances where they do work with the doctors there in the inpatient unit, and they get placed on a medication that they're willing to take. There have been also a few examples of youth coming back on long-acting injectables, LAIs, so they can continue to take the medication once a month with the proper consent, obviously. So that would be what you described is a very complicated scenario that we have to address clinically on a case-by-case basis.
Right, and I feel like the scenario that you're describing is like the most serious, right? Where there's like the young person is deteriorating and requires significant like medical attention and supervision. But I wonder if you're aware of like all of the other young people who are in the less serious situation, but who simply refuse to take their medications because they don't like to. And I'm not sure that you all understand the implication of like what it means for a young person to refuse to take their medication in court. And I think that's like the disconnect that I'm seeing and worried about in terms of how it affects young people when it's reported to the court. And it's, it might not be the situation where the young person is deteriorating.
Yeah, I think it should not be a punitive. I agree with you. It should not be a punitive situation, and it's clinical. It's purely taking us recommending medication, prescribing medication, and the youth agreeing to take medication is strictly a clinical process. And when the law affords them the ability to assent or to agree to take medication, notwithstanding the parent's consent, it is total. There cannot be a punitive attachment to it. And I absolutely, I echo your sentiment.
Yes, thank you so much for that answer. I still didn't understand your answer, though. So it is clinical, but once the judge has said, okay, I'm overriding the parent, the youth, everybody's decision, this youth must mandatorily take medication, should the youth, where it's not an escalated situation, should the youth say, no, I'm not wanting that medication, does clinical write a report to the judge that has ordered forced medication?
Unless we're specifically asked, we don't. I mean, we don't just automatically generate a report to the court saying youth is taking or not taking medication.
Yes, Dr. Gongora?
I actually think it's a question for probation. Does that get reported in any way in any of the reports that go to the court?
Thank you. Yeah, not to Ms. Kakani's question, no. So unless it is the extreme situation that I have to say I'm sitting here thinking about in the last 10 years, I cannot recall a situation. Doesn't mean that it didn't happen, but in my experience, it did not happen. unless there is a direct order from the court requesting information about treatment and medication, which we would then ask medical to provide. We don't report it as, I think the concern is a violation. We do not do that in probation.
Much, and we obviously did not give this agenda item enough time because we are over, but there's so much to it, and there is not just one right answer because it's by a case by case factor, which I totally understand, but I think I have like 10 more questions now with all the information that's been provided. So one last question from Commissioner Terry, and then we are going to move on to public.
Does the medical information travel with the young person if they go to county jail or to another placement or even home? Is there a transition plan? Are those records, it follows them?
Yeah, it definitely follows them. They get a discharge summary. We provide a month's worth of medication to whatever pharmacy they want us to send it to, or they can have a paper prescription that's included in their mental health packet. So probation does a packet, and we do a packet too for mental health, and so does medical. So all that information and prescriptions are sent with them.
Okay, and then only because it's come up twice now that Ms. Gluckman raised about partnership, I'm just wondering, what would a stronger partnership look like? Are there not regular meetings happening? It sounds like you had mentioned like not having a seat at the table, so what would that actually look like beyond the sleep examples you gave, which were really helpful?
Hi, thank you. There are regular meetings. I think, so I don't know if they're having psychotropic med regular meetings, but we still are having the substance use meetings, which, as I said, we still fail to have appropriate policy and training and a whole bunch of things that are still due. That we still want to work with probation, and probation isn't at those meetings every couple of weeks. And then we also have a once a month meeting as well, which again, I just want to point out that Dr. Demurla and Dr. Fitzpatrick are regularly at those meetings, but we really need jointly to have someone from probation at that table.
Thank you so much. And Wendy, do we have public or written comment on this item?
Thank you. Janae, do we have already submitted written public comment on this item? I don't think so. If you'd like to give public comment, please approach the podium. As you're doing that, I just want to say thank you very much to the panelists and the commissioners today. This was a really robust presentation and I learned a lot. Thank you. And so we'll start. Do we have the clock? I can't see it. It's ready to go. Okay, you've got 2 minutes. Welcome. Thank you for being here today.
Thank you. My name is Rochelle Amesco. I'm the director of the Juvenile Justice Clinic at Loyola Law School. I want to give you a few stats for some of the young people we represent. A 15-year-old male weighing 128 pounds is prescribed 150 milligrams for 6 months of Benadryl for sleep. A 14-year-old male weighing 124 pounds is prescribed 100 milligrams daily for 6 months for sleep. For reference, a single adult dose of 1 Benadryl tablet is 25 milligrams. And most adults who've taken a single dose of Benadryl know how drowsy a single dose can make a fully grown adult. At least I do. There is a concern about young detained people not being able to sleep. Indeed, I am sure the number of young people detained actually wetting their beds at night due to the trauma of removal from their communities is even higher than we know. In addition to the trauma of removal, sleep disturbance is a common symptom of ADHD, ADD, and other neurodivergent issues and other mental health issues generally, as I'm sure you are all aware. I was asked, what I have seen in court and through my own interactions with the young people that we represent is that Benadryl has an impact on the daily functioning of young people, which can at times manifest as negative write-ups and behavioral issues. And for the record here, every single denial of a young person who chooses to not take their medication is provided to the court in a report, and we are often litigating those issues. I have asked on numerous occasions in court, and the court has ordered a report from DMH on the long-term effects of diphenhydramine on young people with neurodivergence, and long-term effects such as dementia and long-term reliance on sedatives to treat underlying issues. When we sedate our young people on long-term use of extremely high non-FDA approved lengths and doses, we impact a young person's reliance on sedatives. This is a huge issue, and I am grateful to the commissioners for bringing this up, and I hope to receive a report soon based on the court's orders. Thank you.
Thank you very much.
Hi, Kevin. Good morning.
Hey, good morning. Thank you, Director. My name is Kevin, aka 5150. So I remember when President Mondo was in charge, he always making sure that we have equal amount of time across all items. But today you take 2 hours in one item, so I don't know how are we going to continue the systemic racism against all other items. So I'm a little bit concerned about that. Second is that I think Commissioner Jackson asked a pretty good question that about misinterpretation of symptoms, about misdiagnosed of certain individuals. Yes, because I remember that some of my professors reported me that they told me that I just cannot put my hands down in the class. And they reported me to the dean, and then the dean said, well, there's nothing wrong, go back. So yes, I'm definitely a little bit concerned about that, because there are some people are saying that, hey, I need on mental health, I need on drugs, I need on this, I need on that. So I'm glad that I didn't go to the probation department. I went directly to a state penitentiary. Otherwise, I think end up in the probation, you guys gonna drug me. Now, continue about the sleeping aid issues, about the sleeping aid issue from the Commissioner Kakani. Did you guys went to the Chinese airport or maybe the Japanese airport? They have something called a sleeping pod. So you can Google it yourself, go to the airport, see it yourself. So sound isolation, light isolation, quiet temperature control. So if you want a best sleep of your life, a typical coffee shop of China, Japan, they have those special sleeping pod. So maybe that is something that you can look into, but I don't know. But yes, I really do have a million questions about this, because I just hopefully people don't get drugged when they don't want to, because I was trying to, some people trying to drug me, but I say no to my parents.
Thank you, Kevin. Yes, Mr. Bell.
A lot of information. So I hope I ain't asking questions that already been answered. One, with the kids that come inside already taking medication, are you guys in contact with their medical record or doctor on the outs to make sure they're actually taking that medication and that they're taking the right doses? Or you guys just ask the kid and parent and go off their word? Because that's not always the best thing. Two, the kids that are inside and they haven't been taking the medication and they start taking it while they're inside the camp. That is my concern, because I've actually seen kids talk to other kids to tell them what to say in order to get this medication. Or I've seen kids who, I just want to go to sleep faster. They don't really need it. They just want to sleep faster. So they go out and try to get prescribed Benadryl, which does have side effects. I think dementia or something I heard about in the long term. But they don't actually need it. They just want it. So how do you guys look at a kid that's already inside and say yes? Or is there a time where you guys could say no? Based off everything they tell you, you determine no, you're not getting the medication. Or do they all just get it, start taking it, and then you see what happens after they take it? Because a lot of these kids as well, they get talked into getting these medications so that they could share with other kids. Now those medications end up in a bottle full of water mixed up, and now the whole dorm is taking the medication. So how do you guys go about saying no to a kid when they actually try to get the medication as well? Thank you.
Thank you, Mr. Bell. Dr. Demrella, can you answer if you were able to, because I know Commissioner Shipp had that question also, if you talked to the doctor prior?
I'll also have Dr. Fitzpatrick join me, because he actively sees patients as well. Yes, we do verify, we corroborate the information actually, our nurses, the first task at hand when a youth walks into the juvenile hall is to find out if they're taking psychotropic medications. It's one of their items that they have to go through. And once they get some information, they immediately call the parents and try to get as much info as possible about the medication, the dose, the frequency, compliance, and other things. Only upon then will they call the on-call psychiatrist, and the on-call psychiatrist also looks into the appropriateness and of the medication, the dosage, and other aspects, and then they usually continue it if it's deemed that the youth has been taking medication for 7 days, but only to be followed by psychiatric evaluation and follow-up within a day or two of in our facilities. So Dr. Fitzpatrick is also one of our on-call psychiatrists. So I just wanted him to chime in too on this.
Oh, yeah, absolutely. And I guess the crux of the question is collateral information. How do we obtain collateral information? Do we respond just to what the youth tells us, or so we use parents. We do get a release of information from the prescribing physician, and we have probation to do sleep logs. What time they've fallen asleep? Are they staying asleep? Because there's about 10-minute checks that they usually do every night, and just to jot down, okay, they seem to be sleeping or not sleeping. So again, collateral information. Parents, we would ask questions like, did they have any sleep problems when they were at home? And when they did, if they did, what medications would they take, if any? We do have a protocol for between 2 and 4 weeks of sleep hygiene before even referring to a psychiatrist to consider any medication.
Thank you very much. And we are over time by a lot. And, you know, sometimes though, the interest of the people is greater than the interest of the time.
We have one online public comment. Sorry, it just popped up.
Okay,
Can we
and
take
we
that
just
really
got
quick?
an online, and then I
Yes.
will close and ask the commissioners if they have any closing questions.
Okay,
before-
so we'll take one online public commenter, Derek Blassingame. We'll unmute you. You may need to unmute yourself as well. Derek, can you hear me? You're unmuted on our side. Okay, well, I welcome you to try to work on the audio issues and comment at a later time during the meeting, but with that, we can move on.
Okay, thank you. Commissioners, do you have any closing questions? Yes, Commissioner Ship.
Yeah, in brief, and I've been thinking about this, like in brief, can you talk about that aftercare piece, right? Because for a young person coming in and out, they may not always have access to those drugs. But for somebody who's staying a lot longer, they may. Or is that something that we are prescribing them the drugs and giving them longer dosages? Are we paying for that? Is that the county paying for it? Or just how does it work in general? Like you mentioned aftercare, but I would love for you to expand on it a bit.
So we established the J.J. Tots program, DMH did, Juvenile Justice, Transitional Outpatient Treatment Services. And Dr. Streich, who's sitting in the audience, and I had initiated that program. And we also have a strong presence of psychiatrists in that team. So even before the youth gets released, while they are still in the facilities, we have a J.J. Tots referral for every youth that is placed. Initially, this was only a pilot for camps, but we have expanded it to all the youth in the county. And so we did it with existing resources. So our own psychiatrists in the facilities go to these various area probation offices typically to see these youth. And so we have them in different areas throughout the county. We also do some hybrid whenever necessary. Especially during the pandemic, we did have to do a lot of virtual. But lately, there's in-person on-site sites that are open for our J.J. Tots psychiatrists and clinicians. So it's once again, our J.J. Tots program is Medi-Cal certified, and so The good news is that our psychiatrists and the JJ TOTS transitional outpatient treatment services, their main goal is to make sure that the medication is continued by the psychiatrist because we don't want them to slip through the cracks. And secondly, provide them with solidified linkages in the community to other DMH directly operated as well as contracted clinics. And also assist them with various other situations. Say, for example, if their Medi-Cal is not active, or how can they reestablish that? If they're having any type of problem, then it's not just a psychiatrist, but they work like a team with other clinicians to try and problem solve with other issues that they may be having. We also are able to continue MAT medications in that on that platform, the JJ TOS platform. Yeah.
And to also answer your question, there are sometimes when Medi-Cal is suspended while somebody is detained, and DMH provides an insurance for that. It's called Magellan, and it'll cover the medications until they're linked to somebody more permanent in the community.
Commissioner Shipp, I actually think your question might be worthy of a full presentation at some point in terms of not just aftercare for young people leaving detention, but also youth on probation in the field who never come into detention and adults on field probation and their access to DMH services and other services for mental health issues. I think there's a lot of work that's been happening and is projected to be happening that might be a useful presentation in the future.
Thank you. Commissioners, any more questions before we close? With that, panelists, thank you very, very much. You came with so much information, and thank you for your time. And we look forward to talking again soon.
Thank you, Probation Commission, for having us. Really appreciate it.
Thank you.